Hello everyone, good evening again. I am Shaboni De, the research assistant to Sarvodaya the Rice Foundation, and I welcome you all on the eighth webinar of SarvArogya on the topic of digital public health infrastructure, India's blueprint for healthcare transformation. We are honored to have Dr. Mayank Badola sir, CMO LBS NAA, as our expert today. Please keep your mics muted for discipline. And if you want to ask question, you can drop it in the comment section, or maybe you can save it for the later. Now, I request Neha ma'am, editorial director, Sarvodaya the Rise Foundation, to welcome our expert and provide a program overview for today. Thank you.
Thank you, Shrabani. First of all, good evening, everyone. I'm delighted to welcome you all to the eighth webinar of SarvArogya. Also, I would like to extend my sincere gratitude to Prasad Institute of Medical Sciences, Lucknow, for supporting this initiative. First of all, on behalf of entire The Rise family, I welcome Dr. Mayank Badola, who is presently the Chief Medical Officer at the Lal Bahadur Shastri National Academy of Administration. We are truly honored to have you, sir, with us today to share your insights on digital public health infrastructure, India's blueprint for healthcare transformation. Now, but before Dr. Mayank Badola sir expresses his thought, let's set the context right. Let me begin with a simple question. Banking has gone digital, communication has become instant, education has also moved online. Then why should healthcare remain an exception? Why do we still need to carry our medical files from one doctor to another? See, the answer lies not in the technology, but in how these health systems are designed. Healthcare is something that demands trust, it demands continuity in care and coordination across stakeholders. This is precisely why digital public health infrastructure has become such an important policy priority. Pandemics like COVID, where management required both speed and scale, have made it clear that digital public health infrastructure is no longer a luxury. It is rather a necessity. And in fact, India has already made significant strides in this direction. But we need to understand technology alone cannot transform healthcare. In India, still millions of people are still unfamiliar with concepts like informed consent and data privacy. And it's not just awareness, trust is equally important. Now, just tell me, can a villager in Bihar place the same level of trust in a digital consultation, or do they still prefer meeting a doctor at a clinic? Because we need to understand that ultimately technology succeeds only when people trust it. And trust alone is not enough. It must be supported by these systems that work together. This brings us to another pertinent point, that is the piecemeal use of the digital health tools. India has built remarkable platforms, be it Covin for vaccination, Nikshay for tuberculosis, eSanjeevani for telemedicine, Uvin for immunization. Each has transformed its own domain. But these are just isolated digital success. A patient is not just a vaccination record or a TB record or a teleconsultation record. They are one individual with an entire health journey. Our digital systems must reflect that reality. They must communicate with each other. They must be interoperable. And India has already begun this journey. We will know more about this in the webinar. Also, the digital public health infrastructure is not just about the apps. Interoperability is not achieved just by connecting one application to another. It requires standards, it requires rules, it requires governance. Building a digital public health infrastructure is an institutional reform. It demands strong policies, cybersecurity safeguards, financing, capacity building, and collaboration between governments, healthcare providers, and technology partners. And India is building this vision into a reality. And that is precisely what we hope to explore through this webinar. Shravani, over to you. Shravani?
Thank you, Sneha ma'am. Now, I request Sneha ma'am to share a brief profile of our esteemed guest.
Thank you, Shravani. So, Dr. Mayank Badola is a distinguished public health professional with extensive experience in healthcare policy, system management, and program implementation. With an MBBS from Tirunelveli Medical College, Tamil Nadu, and an MD in community medicine, he has dedicated his career to strengthening public health services. Currently, as a Chief Medical Officer, Labasna, Sir is actively working on integrating public informatics for tuberculosis elimination. His career spans emergency medical services, clinical management, and leading critical public health programs. As the former state TB officer of Uttarakhand and an additional project director at the Uttarakhand State AIDS Control Society, Sir has played a pivotal role in managing the national health programs. Additionally, as an assistant director at the State Mental Health Authority, Uttarakhand, Sir has contributed significantly to mental health development and research. With expertise in healthcare analytics, quality management, digital transformation, Sir combines research, policy development, and implementation to drive impactful healthcare reforms. His contributions to epidemiological studies and national health initiatives highlight his commitment to improving healthcare delivery and patient outcomes. Sir, we are truly honored to have you with us today in this SarvArogya webinar. Over to you, sir.
Thank you, Snehaji. Thank you for that lovely introduction. And I hope I'm audible to you. Right, please. So, so today, actually, I'm linked with one of my phones as well. You can shut that thing, the video feed from my phone, probably. Yeah. So there is some issue with the network. So that's why I'm connected so that, the connectivity is not lost. So thank you for giving this opportunity. And I'm sure this lecture will be helpful to all those who study public health and are from the background of public health or community medicine or MPH. And in this particular slide, I will be actually talking about how and why we should digitize. I will also be talking about the topic like policy initiative which India has undertaken in the past, so last 10 years, and how far we have gone ahead with them. What is India's stack all about? And then we'll talk about one of the slides will talk about ABDM, Ayushman Bharat Digital Mission, and Unified Health Interface, which we are in the process of making. Then we'll be also briefly touching upon Digital Personal Data Protection Act, which actually secures all our data, especially the health data. We'll also talk briefly about SAHI framework, that is how artificial intelligence is to be tackled in the health sector. We'll see some use cases of AI in health sector, global architecture models, how different countries are tackling this, the digitization, and what are the various frameworks they are using. We will also examine critical gaps, also discuss some of the research agendas, which probably your audience can, go ahead and think of researching upon in the time to come, and what way forward is there. What are we doing? How we should manage digitization? How India should lead the thing for the global south? And that's what this whole presentation is all about. Can somebody upload the presentation?
Yes, support team, can you please share the slides?
Or should I share mine?
So we'll share it.
Okay, right.
There,
Thank you.
right. Yes, sir.
So, first slide, please. So, right, essentially, why we should digitize? That is one of the main question which had come to us long time ago. We tackled it. we had to think it over, what all has to be digitized, how to digitize, what about the security issues, how, I mean, in a fragmented system, how are we going to digitize? It is, there are so many number of questions, but obviously all the pros, why we should digitize, because say it is more faster and efficient. There'll be more fewer number of errors when we digitize our data. There'll be easy access to the data. We can plan accordingly. We'll be saving a lot of money. There'll be transparency which will come into the system. Long term, we'll be saving money, and there'll be better user experience and a chance for innovation to hook in AI. We can make use of AI. That's why digitization is all the more important, and these are all its advantages. But there are certain disadvantages as well. For example, if you are sitting in an emerging country, I often teach a lot of people coming from Southeast Asian countries, from African countries, and I often find that their population base is quite small, and their issues may be very different. For example, if you are from a Caribbean island nations, population is very limited. They are farly separated. They are into different islands. There are logistic issues. So, of course, digitization will help them, but in a different manner than what India is handling. So, we are a large population base. We have a lot of people living in the rural areas. We have good connectivity now. We have established it. We have made conscious efforts to establish good connectivity. These are some of the advantages which India has. But there is always an initial high setup, even for India. And there is always an issue of migration of previous data. What all has been done till now, how to migrate it into the new system. It is a very costly procedure, and it's a hidden cost whenever we are digitizing any system. There are, of course, issues of cybersecurity and data breach leaks, which are all the more, possible in the era of AI. And a lot of data loss has happened in India earlier, and is likely to happen again if we are not conscious about it and we don't spend money on cybersecurity. So these are some of the issues. If you are in a paper trail method, or if you are in a undigitized method, these kind of things cannot happen. Then there is a issue of digital divide, whether all the users are going to take advantage of this digitization or not, whether it will be so effective and people will accept it or not. Are we satisfying their needs or not? These are some of the cons which digitization brings about. Then there is, of course, a lot of resistance at first, right from the institution itself, because transparency is there and a lot of people don't want the transparency to happen. There may be difficulty in, retraining the staff. They may not be happy with it, especially in the health sector. So these kind of issues are also there. And privacy concerns are some of the most important things which people cannot compromise with. So privacy is the privacy of their data, and whether they have control over their data. That is one of the important things which any digitization procedure should ensure. Of course, then you have to maintain the system continuously, and you have to also train the staff continuously. Every time there is an innovation, every time there is a change, you have to again, train the whole staff. So these are some of the cons of digitization. So whenever any country or any place is planning to digitize, be it health or any other sector, you have to arrange finances first, make policy decision, privacy and cybersecurity decisions, and ensure connectivity and training. These are some of the important things. Mind you, when ABDM came, even now, even so many years down the line, we are still struggling to digitize all the periphery centers. We are still struggling secondary centers to get them adequate number of computers, connectivity, and things like that. Of course, India is making efforts, but since ours is a very large system and very different geographies are there, there are different languages are there, so it itself offers a lot of resistance. The system takes time. So as you can see in the slide, if we have mapped this transition from a fragmented initiative to a unified architecture. So up until now, before 2015 and our last health policy, all the data was in silos. When NHM came, became National Health Mission came, and a lot of 13 to 14 programs are running under that. So everybody had its own HMIS. So if suppose we want to follow a TB, and TB is one of the best longitudinal data which is available is for tuberculosis. So there is Nikshay software for it. Then if you go to viral hepatitis, there is another vertical software, chasing it. Maternal child, another vertical. So vaccination, another vertical. So these were basically for program management. There were several programs which are managed by the program manager. Ultimately, the MD NHM will go through the data, center will go through the data, they'll review it from time to time, but it was all vertical data and it was in silos. So every program had its own HIMS inbuilt in it, and a lot of times they were not equally effective, not equally granular. I would say tuberculosis and AIDS control probably had the most descriptive data available, longitudinal data available, and they were the most mature program. They have been working very well and they are still improvising in it. So till then it was all siloed. So every vertical had different data. Plus you didn't have any way of data talking to another data. Is there any problem? Am I audible?
Yes, sir,
Hello.
you are audible. You are
Right.
audible.
Right. So that was the issue before 2015 and all. Then India launched Digital India campaign, wherein we have actually worked upon DigiLocker, UPI. We have also increased BharatNet and all, so that digitization, we are able to provide connectivity to the peripheries. So a lot of things are required when we digitize. Amongst them is infrastructure interoperability. Infrastructure and interoperability, you have to have the same standards, then only one machine can talk to another machine. If you take MRI in one place of India, the other person should be able to get it and interpret it. That kind of standardization is required. You need a good high level of connectivity. So India has come up with BharatNet, wherein they are linking all the health centers of India, right from CHC, subcenter, PHCs, everything. It's still undergoing. A lot of investment is required. So it is under process at the moment. In certain states, it's fully digitized. In certain states, it's not. Then transition is required from vertical server-based platforms to cloud-based platforms. This is again a systemic change, which requires a lot of efforts. I mean, it is easy to start a cloud thing, but getting a legacy data from a vertical, structure to a cloud is again a hurdle. One has to think about it. A lot of data and governance and trust issues are there. So you have to have good security and privacy control. You have to have unique health IDs for the doctors, ID for the health facilities. These have to be built up. There has to be a clear consent management system. As far as clinicians, the training of the clinicians is required. The training of ASHA, ANMs are required. How do they digitize the data? They have to provide them with tools and apps so that they can easily digitize the data, and it should not burden the system which is already burdened. And there should be a clear transition map from paperwork to digitization. That kind of thing is there. Lot of strategy work has to be done even before strategize. You have to do ensure that you have a right strategy. So as you can see, from 2015 to 2026, we are continuously working. These are all some of the important strategy papers and important papers which help us to digitize. So as you can see in national health policy, it had already mandated that we should have completely digitized electronic health records, but it took time to actually bring about the change. Again, Ayushman Bharat Digital Mission in 2020, and they actually created the backbone of how to digitize, how we will go about digitizing. Then you have Digital Personal Data Protection Act, which came in 2023. These are some of the acts. I'm not going into the detail of them, but these are some of the acts which all the people from public health should go through it, should do a critical analysis of each and every strategy. For example, the latest strategy which has been floated this year itself, that is strategy for AI in healthcare. If you just go through the documents and you do a critical analysis of the document, hardly any papers have been published till now. And you will realize, when I did the critical analysis, I could find out that this particular strategy was not backed by any finance as such. There were a lot of issues regarding gray areas in AI and how to actually procure AI services. These kind of issues, if you go deeply and study each of every document, you will come to know that still it's work in progress. A lot of researchers are working on it, a lot of institutions are working on it, and a lot of fund is being diverted, to strengthen such mechanisms. So
Yeah.
So, right. So coming back to the, what India did and how the whole stack is. So, and the bottom you can see there is the identification layer, which is Aadhaar. All, even our Aadhaar and everything is linked to our phone numbers and Aadhaar. So ultimately, Aadhaar is the, base stack. Then you have the financial stack, that is UPI payments. Anyhow, if you are interacting with any hospital, be it government or private, you have to pay. So there is a payment layer. Then there is this data exchange layer, which was a new thing. We wanted a common cloud-based data exchange system, wherein is, if suppose you walk into a hospital and you get a free treatment, free care, rather it is a insured treatment. There is a lot of back-end work done between the hospital and the insuring agency, whether it is a government agency or a private agency. So that kind of exchange of data, exchange of information, you require a separate channel for it. That's what data exchange layer actually does. Plus, it has a lot of information floating around, which has to be linked to the person, linked to the doctors and the institution. So that kind of work is done by data exchange layer. And then you have the health application layer, which is ABDM, where we have the, we can, with the help of the APIs, we can use different apps. We can, make use of the data and generate different information, whether it is from the programmatic point of view or for the patient himself. And it has to be secure, and the finance has to be seamless. Plus, if suppose you are giving a service like, say, example, telemedicine, I am a patient and I want to talk to you. So it should be seamless. I should be able to book the appointment, and then the doctor should be there at the appointed time, and I should get the services. So that kind of, intelligence layer by layer has to be built up, and we are actually have been able to achieve it. Whether it is being adopted by the public at large right now is still questionable, and it will take time. So we are maturing and also, floating the apps and all sequentially. So it takes time, but then we are heading in the right direction. Next slide, please. So as you can see, ABDM had one or two mandates which they had to tackle. So one of them was that they should have they should have Abha number. Somehow my thing is not refreshing. Can you see the Abha slide?
Yes, sir, we can see it.
Right.
Can
So,
other interns indicate whether they can see it or not? Okay.
Great,
Yes,
great.
everyone can see it.
Great. So my slide somehow is not changing. Anyway, so basically you have a universal ID, which is Abha ID. I'm sure some of you must have actually created it, whether you created it yourself or you walked into a hospital and somebody created for you. So essentially, if you talk pan-India in progressive states like Andhra Pradesh and Karnataka or Tamil Nadu and Kerala, if you walk in, the hospital himself or itself creates an Abha ID so that your longitudinal records are linked to you. So Abha ID is actually a 14-digit unique identifier. And here, how we are different from many other countries is, if you go to talk about USA, UK or other places, the social security number is the only number and everything is linked to it. Whereas in our case, we have de-linked our identity from, that is Aadhaar, from our health records. So privacy, to just maintain the privacy of health records, and suppose somebody wants to do some mischief, they are not able to get our health IDs. Only we are in charge of our health data. So that is why we have de-linked everything, and Abha is a unique identifier. Everybody is issued a Abha, and it is certified or authenticated by us with the help of OTP. If you just go, or some of you can try after this session, if you have not tried, just go. It is a simple, one step procedure. You simply go, give your phone number, your details, and you can just create an Abha ID. And later on, if you want to share your data with any hospital, you have to just generate this ID, and then you can share the data with the hospital concern you want to share your records with. So that kind of thing is there. So already you can see 870 million plus accounts have been created since 2020, which is a huge amount. I mean, it is not happening anywhere in the world. We are the second most populated nation in the world, and this is a huge achievement, and it's already taking pace. So patient control PHR, again, it is in the hands of the patient. If you want to share, for example, must have used DigiLocker, because we first had we were able to make use of DigiLocker. What I could find out, a lot of people had challans and all, so they were very happy that DigiLocker is there and verified records are always there. Even the police people were sensitized that if somebody is showing a challan on his phone with a DigiLocker, it is valid, or you are going through a DigiYatri software. So DigiLocker came about, but similarly, we have a locker here, and all your health records are, inside PHR, and anybody can access this provided you give the permission. Can somebody open this ABDM slide, ABDM icon? Can you click it? Sorry, yeah. Anyway, so what I had tried is I had linked this to the ABDM. So if you go to ABDM website, basically, essentially, if you go to ABDM website, you can
Sir, the website is right here.
Right. So if anybody who is interested in further reading, please visit this website, and you can see here that this is basically a dashboard for public, for people like us. If you can just scroll it down and up, you can see how many ABHA IDs have been created, how many verified health facilities are there, health professionals are there. Further, you can, just all kind of data which is being generated is visible here. How was the trends? How many people registered? When did they registered? What were the trends like? So these kind of intelligent systems are already functioning for the past so many years, and people are there, program managers are there chasing down these particular leads. They are trying, whenever things are going down, they look at the policy decision, why a particular state is not doing well, which state is doing well. So that kind of, and whether Ayurveda, even you can see different modern medicine, Ayurveda medicine, everybody is supposed to digitize and create an ID. So that is how, it is being chased by program managers, and everything is now visible in the dashboard, and it is all live data. Thanks to the cloud, everything is live. If there is a shift of one data point in any state, it is reflected in this particular section. We can go back to the slide, and when you get time, please do go through this particular website. All the details regarding ABDM, what the policy decisions have been taken, where public consultation is being sought, everything is available over there. So coming to the next slide. So essentially, what ABDM tried to do was, they created an ID for the patient, which is ABHA ID. Then there is a health professional registry. So if you are a doctor, you have studied anywhere, and you have practiced whether in the private sector or in the government sector, everybody is supposed to have this give their details of their degree, their address, their phone number, contact number, email IDs. So we are creating a database of all the doctors. And what is the incentive behind it? The government has ordered all the government doctors to register here, and the private doctors are incentivized. So if they register to this particular facility, they are given free of cost HIMS, or at a very nominal cost of 250 per month. So they get a fully linked cloud-based HIMS for maintaining their patients, their records. They have a telemedicine facility there. You have a call-in facility over there, and it is all built in by CDAC. And this is what is driving people to private personnel or doctors to register in health professional registry. And it is mandated in each and every step, whether you go for MCI, for registration of your council certificates and all, then also they'll ask you to so it is done at the back end also, and at the front end also. So the whole idea is, every professional should be having an ID. They should be linked to the same system, whether they are in the private sector or in the public sector. So again, this has a hidden advantage. You can't have digital quackery. Everybody is responsible for their own, perceptions and all. And those who are actually not having valid certificates, they will not be accepted here. They have to upload their degree documents. Everything is verified at the back end, and then only they can join it. So you are doing several things by just creating this registry. You are eliminating not just digital quackery, the real quackery, which is a bigger question. So only people who are authorized will be able to register here. And that is one of the important things that this kind of registries bring you out. Another dearth of data which we faced was that none of the facilities, a lot of times, if even when I was a CMO or managing the state during COVID times, very little data was available as to how many facilities are running at the moment in my particular state, or in my particular unit, or sub center, or say in the periphery. So that kind of intelligence was also required. What is the facility, what are they offering? So government has standardized our facility. CHC is supposed to give certain amount of things, PHC is supposed to give certain amount of things, sub center. But what of the private sector? So private sector, we had to again have intelligence. Either we had to send a third party to verify their credentials, their details, and what all they are offering, their phone numbers and all. But now we have created a registry wherein all the health facilities can register themselves, and that is advantageous for the government also, especially in case of epidemics, or if there is large scale disaster or something. So that kind of intelligence is being being made right now. And IDSP is one of the things which is working upon it, and they are also collating a lot of data. So every data in the backend is merged. No matter what the source is, the data is being merged at the backend. So we have this health professional registry, ABHA ID, and then there is a health facility registry. That slide is missing. That's why I'm telling you about it. Next slide, please. So ABDM came up with this again, a very unique thing. Earlier, when we were, working in, say, for example, eSanjeevani for telemedicine, it was a vertical. So one had to log in, create a, ID, password in eSanjeevani, then you go book an appointment, whether you get the doctor or not. Then you wait for him, the specialist concern, and then you get the appointment. You get a digitized, prescription, which you can go to a chemist and get the medicines. But there was a catch in it, that not every system was talking to each other. Privates, how will they join that same eSanjeevani kind of a thing? So we have now a connector block which is known as unified health interface. So no matter what kind of app, for example, if you have an app, say Telemanas, or something, a private person has developed, for example, counseling app, or a helpline for preventing suicide, so, or de-addiction site, or anything else. So that kind of apps can now integrate with the connector block, and this is a unified interface. So it has all the data, and it may helps us. Everybody has to generate an API. That API gets connected to this, and then you can get connected to another system, probably with the doctor, with the hospital, something like that. So this has actually eased you don't have to create a vertical every time. It is already there. Backend is already there. You have to simply plug in and play. So that kind of thing has been, developed. Again, UHI, if you want to read about it, there is plenty of information again in ABD website. You can know about sandboxes. If you have come up with a new app, nowadays I know a lot of doctors and even public health professionals are building their own apps, and with the help of AI. So you can always go and explore what is the need of the hour, what kind of things government is looking for, and you can develop. If you are a developer from the IT sector, you can sell your apps to the government directly. So UHI is an open kind of a setting where anybody and everybody, even from the society, can contribute to it. So that is one thing which everybody, health professional, should think about it. Next slide, please. Again, here I have tried to explain that, for example, standardization of all the data is required. So you have SNOMAD, Loinic. So these are all HL7, FL, HIR. These are all standardized data. So you can exchange, the machines can talk to each other. The data is in a standardized format. It can be utilized by, so for example, if you get your, say, first investigation done in, say, Lal pathology, then you got the second investigation in some other pathology, or you got it in a government pathology. At the end of the day, the data will be standardized, and whether the front end will be different for each pathology. Whatever report you are getting will look slightly different, but back end will be same. So it will be read by the computer easily. So that is what we mean by interoperability. That is what I mean the standardization of data, and it has been done. All the labs, they follow LOINC methodology. All the CT and MRI, they are on SNOMED. Then again, all the health clinical data is on FHIR. So these are the standards which are there, and everybody is expected to fall onto them. It is almost like having a charger pin which is standardized. So now you have C2 charger, so every phone will come with a C2 charger. So every lab has to follow that standard, and that's why the data can be read no matter where you go. So these are certain things which were essential, and we have been able to achieve it. Next, please. So then there are legal and ethical guardrails. So that is one of the things which time and again, especially in terms of AI, when the AI came, these kind of questions have come up really serious, have become really serious. Why? Because data loss, privacy of data, again, a lot of issues are going to come in the future. So we need to ensure that. That's why DPDP Act came into existence, and it is also continuous work in action. There are rules which are being made very recently, and there was a lot of public deliberation, what kind of act it should be, what kind of data should be protected. If somebody breaches the data, what should be the punishment? Suppose some hospital shares your data, what will be the punishment given to that particular institution? These all are dealt with in DPDP Act, and those in the public health domain should go through it. This is a very essential act, and this is how all your data is governed. So data principal is your patient, consent manager is the intermediary, and data fiduciary is the hospital which uses the data. So every time your data is used, you will be asked for it. Every time your data is used by a hospital or an insurance firm, you'll be asked to generate a OTP. If you give sanction to that particular hospital, they can see your legacy data, your previous data, and take a decision. So earlier there was no, people used to carry all their files, X-ray, CT, everything with them, used to keep them. And most of the people in the villages and lower socioeconomic status were not able to even keep them safely. So that was one of the challenges, which is definitely met with the help of digitization, but you need to control it. That's why this act came into existence. And as I say, like for example, mechanical engineering for making a car, and mechanical engineering making a rocket for ISRO. Both are mechanical engineering, they follow the same principles, but you have to be very certain, it has to be fail safe, human life is involved. So that kind of sensitivity has to be built in the system, and especially when you are dealing with the healthcare data. If it is a data from your electric meter, it has little chances of getting misused. So and it is generated daily. Similarly, your health data, it can be misused like anything. So the idea is there should be responsibility fixed, there should be some kind of penalization, then only it works. Next, please. And last but not the least, now we are in the AI era. So a lot of times, suppose you are developing a new technology or a new system. So like I was in contact with one of the biomedical engineer, and they were trying to link genetics. 100,000 genome project is already, the data is available, it's a big data, and trying to link genetics to mental health. That kind of things are possible. Trying to link your gut health to your other health parameters, that kind of thing is possible right now, and because of the AI. But there are several issues with the AI. It is still again work in progress, but we are in the process of making a framework how to actually use AI. Who will be responsible if a decision is taken by AI and it is wrong? How the punishment is to be met? Till what level we should allow AI? What about black box data? Things where AI will never tell you how it arrived to the conclusion. So just like we do, rigorous, research, and then we publish in a paper, and nowadays we are having, separate type of protocol is there, that if suppose you are trying to publish a AI generated data or data related to AI tool, then how you have to present it, and what all is required when you present it. How will you buy a AI software? Who will decide whether it is doing right or not? What will be the sample size? All these kind of things are undertaken by Sahi framework. It is just a framework, it's a starting point and anchor where a lot of things have been addressed in the right direction. And it is a very important document. Probably next 2 3 years, you realize it's a very important document, but we have to work upon it. There's a lot of finances required, lot of due diligence have to be done even with this document. So those researchers who are into policy making may like to go through it. And essentially it calls on where AI will come into function, how we'll use AI, and where all it can be used. So that kind of domain classification, how to come up with evidence, how to finally convert your evidence into a tangible software or a hardware which you can use in the clinical field. So that kind of question has been addressed by Sahi framework, and a lot of work is being done in IITs. Unfortunately, very little work is being done in the health sector. So there are AIMS Delhi, AIMS Rishikesh, which are nodal agencies. Then there are all engineering colleges, right from MAMC to ISCs. They are doing tremendous work in this field. But I would again say a lot of doctors are required, a lot of people from public health background are required, who has to think about things like ethics, things like how AI, whatever, wherever it is used, how we interpret it, whether somebody, an engineer is claiming that my thing works well for, clinical counseling, whether it works well or not. That kind of, thing has to be undertaken. That kind of research and rigor has to be undertaken by public health community. And obviously, the documents itself are open to scrutiny, and we are all going to work upon it. Next, please. So just a minute, hold that slide. I just forgot there are 2 3 important things. So one of them is clinical decision support. It is being provided free of cost right now to anybody who joins HIMS and who has a health professional registry. If they go to eShushrut site, those who have not gone, go through eShushrut. It is being given free of cost for anybody who has a hospital, and it is developed by CDAC. So there is a clinical decision system. Suppose you write that the diagnosis is acute gastroenteritis, what all you can do whenever you are prescribing, that will be done with the help of AI. AI will be giving you support and telling you what are the probable diagnoses on the sidelines. So that kind of thing has been allowed right now. It is still work in progress. Then algorithmic bias. Actually, if you keep on using a AI for the same procedure again and again, and especially when it has to take decisions, so at times it becomes biased if it is not trained for the Indian population. Suppose you get a counseling software from which is FDA approved, which has done a lot of work in say European countries or Americas, but not in India. It may not work in India. So the idea is that the bias should not be there. Whatever data is trained upon should be Indian. It should be ours, and then only it will work for us. That is the whole idea. And linguistic inclusivity, this is a very essential thing. India, if you are thinking of digitizing and working so many languages, so many cultures, so this kind of thing was not possible earlier, or not possible with the existing tools. So even if Google is able to translate languages, but we have to have our own way of actually converting or translating languages. So that is what SahiNet framework is opting for. We have to have our own systems where we have our own LLM in different languages. And Sarvam, you must have heard of Sarvam. Sarvam, if nobody has read, please go through it. They are actually creating their own ecosystem where our languages can be converted from one to another. Even those which don't have a written text, we are capturing a lot of data, vocal data, and converting and trying to train our models. So that Bhashini platform. So these are things which can link just with the API, and if it is linked to any software, you can talk in Hindi, you can talk in English. Even now everything is getting digitized or written. That's all thanks to AI. So these are certain places where they have been given the liberty to integrate with health, and they are already running. Next, please. So again, these are certain examples. These are no more pilots. They are already, we have been able to show. So there is Netra. So there are these two, you know, Madhu Netra, sorry, and Arman and Garbin. So these are two particular, apps. You can just go to the website, type in Google, and you can just see that they are working really well. They have been piloted and they are now going to be integrated in the national program and they'll be used. So one is for basically eye screening for diabetic retinopathy. The other one is for predictive risk stratification of maternal health. So you can predict if the fetus is going to be delivered even in the 7th month. So there are ways to predict. So that kind of thing intelligence is being developed even in our local MCTS. So that kind of things are already working here, but at the moment it was piloted. It is going to see the day of light within a year or so. Next please. So if we talk in global context, like what is happening internationally. So for example, here I have shown only 3 examples. There are pretty more. You can do a comparative analysis as to how digitization or the way it is being handled by different countries. As you can see in Estonia, it is all centralized architecture. It is highly integrated. All the data is going to one server, one place, and it is all integrated. Then you have Singapore, where there is a centralized nationwide registry. It is again, it is strongly, it is meant for governance. You can, tackle everything. All the data will come to this kind of a server, but they are all dealing with less number of people. So India had 2 3 major challenges. One of them was the population itself. How to scale up? If you are doing a centralized kind of a registry thing, it will take an n number of years to scale up. So for example, now you have UPI. Everybody is using Phone Pay, Google Pay, and others. It is because people are getting advantage of it. They are themselves registering, thinking from, learning from others, and then adopting it. So we wanted to that kind of a system scenario, and we have now moved on to federated structure. We are no more centralized. All the data, when we say that it is on edge-based storage systems, that means it is lying in your hand. It is in your phone. So the phone is the key to all the data which is stored in the cloud, and anytime and every time you can access it, provided you give the permission. So that kind of federated structure is now has come into existence in India, and that's how we are able to scale up in such a large, for such a large population. So it's still work under progress. People are still registering. ABDM, ASHA health IDs are still being created. They, of course, they take time, but then we are in the right direction. And the one of the major hidden advantage of this is, if we are thinking of global south, if you want to say for example penetrate into Maldives can easily link in, or Nepal, or any other country which has good terms with us. They can directly link in with our system. Everything is already up and ready to serve. So that kind of flexibility is there. So think of federated structure and its expanse. We are now working on structures which can be expanded to any extent. It's like having Ola and Uber from here or America. It doesn't make us difference. So we are actually on the right track. A lot of other countries are still holding to, central structures. Next, please. Again, this is again a comparative. If somebody is interested to know in depth what kind of technology is being used by them. So there are different technologies and ways of doing it. There are different reasons for, for example, if privacy is more required, they have gone for, Estonia has gone for blockchain kind of EHR. Again, it is available everywhere, but it is all secure digitally. But you never know, it can be broken also. So our case, it is federated. Everything, OTP will come to me, then only you will know when I have the last dental extraction. If I don't give the permission, the person has to start afresh. So these kind of inherent, pros and cons are there. So if somebody is interested, they can go through the slide, further study different countries. This is only 3, but there are better countries also. USA you can study, and the same lines. So what kind of technology they are using, and how, what is the use case, why they are using this. R is a problem of scale. We have to scale everything for everyone, whether he is literate, illiterate, whether he is in a village, in a city, in a metro. So everybody has to get that advantage. So decentralization is one of the important things. Next, please. And then there are critical gaps. So one of the major challenges for anybody who's working in digital health is how to overcome the digital divide. So digital divide can be between where you live in, whether you have the connectivity or not. It can be even because of the language, whether you know English or not. Maybe those who are in the Hindi speaking belt or maybe interiors of Tamil Nadu, they may not be fluent with English, and they may not get all the advantages which this technology is going to offer. So this is one of the challenges, and there are already different, for example, I told Sarvam and Bhashini, they are working upon it actively for the past so many years, and we are now having APIs ready and ready to integrate with government, portals. And of course, they are offering their APIs to private sector if they want it. So they are competing at the moment with things like Google, things like large language models. So we are still doing better than even the largest language model which is available at the moment. Why? Because we have worked upon it for 5-6 years. Then there is this issue of legacy migration. What will happen to the data which we have generated since 2014 when NHM came into existence and we were doing digitization of data? So how you link it? How, I mean, they will be in different formats. So this is one of the important things which everybody is worried about, how to do it, whether we should forget about it or how to integrate it, because it is all intelligent data. So that is one place where there is a critical gap, and people are working upon it, how to digitize and integrate that data. And then of course, as I told you, algorithmic drift is another issue. With AI, it may be telling one thing in today, it may not be telling the same thing day after tomorrow. It may be talking to one patient in a different manner. It may be talking to a similar patient in a different manner. And these kind of challenges are there. So we have to be very certain what we are developing and what we are deploying at scale. To what extent it should be deployed, whether we should follow FDA like structure, because FDA is already permitting AI based tools to float in the market directly. With you can even go to Google app and see a lot of health based softwares which are FDA approved. But we are very cautious in it, and we are rightly cautious in it, because there are some disadvantages of using AI. A lot of your data and information goes to places where probably you will not have control over it. So this is one of the important things. Next. So coming to what Sneha ma'am had told me, that a lot of researchers are there, and maybe most of them are postgraduates or undergraduates. But since it is an emerging science, it always generates interest. Interest is, I'm sure most of you who are listening to this particular lecture must have worked with AI tools, and because they are in the edge, they are going to make drastic changes in how you actually do your research. So the idea is that we should be always looking forward to new horizon and what all is coming ahead and how we'll be going to tackle it. So I have just given, this is just a kind of a primer what all you can actually study. So you can study about equity. Does rapid digitization reduce or inadvertently exacerbate urban-rural disparities in secondary care access? So these are some questions which probably even the AI doesn't know. It is a kind of a question which probably once everything comes down, boils down to, okay, we have given the app, we have given everything, whether it is working or not. Operational research, it is a part of operational research. So this is where public health professionals have to work, see whatever apps and whether they are making a difference or not. Then you have to see about the DPDP Act, how it is working. Is anybody getting punished? And is it working well? Are there any gaps in DPDP Act which we have to plug in? Once these things start working, we'll be able to generate these kind of leads. So one has to actually think in those terms. Another area probably is what are the drivers of trust? Whether people are using DigiLocker, are they using Aadhaar ID the way it is meant to be, or we have to do something else? Are people living in the villages fluent with it? Or do they want to have it? Or they are comfortable with seeing the doctor and don't want telemedicine? Is telemedicine successful? Are people going for it? Or it is the just a data which is being generated? How far the penetrance is? What are the advantages? Are what are the anticipated advantages and what is actually happening in the field is where public health professionals have to work about. Then what about the AI diagnostic tools? Are they really working well? Is there this TB diagnostics? There are new diagnostic tools. One of them I had the opportunity to work in is VOC based diagnostics. Does it actually really work? How far it is successful in screening people? So that kind of questions still remain and will remain always. So public health professionals should work upon it, should see also what are the policies. For example, CDSCO has come up with policy for these kind of instruments, AI based instruments. It was a non-existent 2 years ago. So because a lot of AI tools are coming, so now we have a policy even in CDSCO that how we'll approve a AI based tool. So whosoever is a developer, they should read through those rules, go through those rules, understand what are the stringent norms and regulations they have to satisfy before their tool becomes a reality and they can sell in the market. So that kind of work is where again public health professionals are required. Next, please. These again clinical validation. Of course, no matter which tool it is, whether it's a software or a hardware, validation has to done after using it on public. And even the edge tools, what you are using in the mobile, you have to first try it out. So public health professionals have to be there. Algorithmic bias is there. You have to check it whether all the data is also tested on the Indian population or not. Whether it is all European only, then the results may not be right. Then these are certain issues which probably can be undertaken by researchers, and definitely it will be fruitful and will have a bearing on the policies which are yet to come, or at least have a corrective actions. You can suggest corrective actions as to what is happening. For example, telemedicine, very simple. Any of the researchers can go assess the data, what your state is doing, see it, compare it with what is happening in the field, whether whatever government is saying or the data is saying that we have done 10,000 consultations. Did it have any impact? Are the people are satisfied with it? Do a KP analysis. You go to the field and just check it out how people are actually using the technology. Can we link telemedicine with say pharmacies pan India? Can we link it to all the schools? Have they linked it till now? What was the drawback? Why they were not able to link? Is there any other better way of using say telemedicine? So these are some of the questions. Whether telemedicine should be there in the urban area, probably in Dehradun, Delhi, or should it be only in the peripheries like of the Assam or border areas of Uttarakhand? So these are certain questions where it will actually work, which can be only synthesized if you do real good work research in this field. Next, please. And finally, the way forward. So these are certain things which have to be taken up by the government and researchers like us. So we have to augment the workforce capacity. So every doctor should be taught what AI is all about. They should be talked about using ethics of AI, how to use AI, which cases you should use AI, whether it is ethically right to use AI or not. So these are kind of a questions which should be inbuilt. AI should be taught to all the doctors as well. It is not only in the domain of say engineering that you require it. Social scientists, everybody is using it. So there should be a systematic way of teaching AI we should start it early. I mean, even now people are doing privately, but they should be part of the curriculum. That's my take on it. We have to empower all our periphery health workers. See, they are already challenged with so much of work. They have so many targets to meet, and then on top of it we are expecting that single asha to also digitize the data. Then how? So we have to provide her with tools, maybe something which where she can just speak and it'll write. So that is the right way of using AI to start with. And you have to have a very smart AI based, without internet it should work anywhere. She can ask question to the AI or her phone, and she should get the right responses. That kind of things can be developed, and I think that is what is required. And everybody should have the connectivity. uh, then there is this thing of pillar 2, where not everything can be, these kind of challenges cannot be undertaken only by government. Just like you can see now, ISRO and a lot of startups are coming up, and they're all supplementing the same cause. So similarly here, sandboxes have been created. It is all, and they are well funded. So all the startups can come up. Even the doctors, very few doctors have actually, in fact, been to ABDM and actually contributed to it. So I would suggest, if you tend to have little bit of, you want to learn something more, please go for, how to create apps, learn it, and think of it in whatever knowledge you have gained till now. What are the drawbacks? What is not happening? What should happen? Think of a gap, and please develop a very small software to start with, and think how it can integrate and help. For example, I can say Nikshay has such a vertical, line list of data. It is available there. Now, how intelligently we can use it is what matters. So the end result, whether a person is getting well or not, will depend on how you use the data. So you can come up with a lot of solutions where, which can be directly used by, ABDM. So think in those terms, study what is happening in GitHub. They are offering, so many links where you can, link with them, and what other private sector is doing, what Max is doing to integrate with IBDM. Have they done anything? So these are certain things we have to, appraise about us about, and we should learn from even the private sector, and we should engage the private sector. The government is already ready, but we have to generate interest in the private sector. We have to incentivize them as well. And finally, everything boils down to finance. Even now, because our scale is so high, is large, lot of finance is required. So the whole infrastructure, no matter how much the policy level work has been done, but you have to have a financing backing to give phones, give connectivity, give instruments to periphery, and it is a huge amount of burden. And I'm sure Government of India is working upon it. We are trying to develop our in-house capacity to manufacture, and that will have an impact on further, it'll reduce the cost, the finances, and then it will take up. So right now, as you can see, we have worked upon a lot of policy work. We have done a lot of policy work, groundwork, how we are going to frame our digital infrastructure, and where we are heading, and finally what we want to do. So that kind of intelligence is already being seen in the government sector, and we are also working on integrating the private sector with us. So these are all good signs, and we need intelligent people like you and others who are working in this field to contribute to it. Whether it is directly or whether it is by writing good research papers, how to digitize a particular field and how best we can, take advantage of digitization. I think this is the last slide, and here are some references, and you can just go through these. You can type it on Google. You'll have a lot of literature coming in, and please go through these policies at least. And the latest one, Sahi, has very little written upon it, very little deliberation or things have been done. So do a critical analysis to start with of Sahi. So that will be the right Sahi tarika isko start karne ka. And I wish you all the best. If there are any questions, I am open to them.
Any questions? Anyone? Please go ahead. Any questions? Anyone? If any questions?
Anyone who wants to ask question can unmute yourself and ask question.
Hello, sir.
Yes, Anmol. Manasi, go ahead.
Hello, sir. Hello, ma'am. Sir, I wanted to ask that we are taking the help of AI in medical also. So, like, if AI does something wrong, who will take the accountability? I mean, matlab, if there is any mistake that happens.
So that is a big challenge. The ethical implication of AI and its decision. A lot of research has to be done. Who has to decide? The Sahi policy, if you go through it, it is really, the developer, whether it will be the developer who will be punished, whether the person who is actually using it, the hospital who will be punished. So that all has been clarified in Sahi. My suggestion is, my idea was to, just, show you where things are going on. And please go through Sahi. A lot of such legal issues have been dealt over there. And even legal people are also working upon it. Okay, how they'll tackle AI. You must have read in the news recently, a person had, just AI generated plea was there in front of Supreme Court, and Supreme Court just rejected it, said it is AI generated, even though it was all referenced, the references were not right. So was it, who should be punished? So of course the person was punished as of now. So the idea is, we don't want to even go to that debate. We want AI to be so secure and use it in a limited manner where we know it is secure, not otherwise. Because lot of things what AI is telling you may not be right. I have, for example, nowadays, when AI started, it started with, developing in health sector especially, were having counseling, softwares. So they have matured over a period of time. Now, say 10, 15 years ago, they were developed in America, but they have matured. And finally, we have realized that they are really good at it also. But they are all trained in American data. Will they work in India? The way we converse, there are AIs which can, just as I am conversing with you, they can find out whether I am depressed, whether I had some issue, whether I am mentally challenged, something. They'll just by visually and by my voice, by my behavior and antics, they are able to predict, and they are predicting quite well. But can we believe in them? They are only probabilities. So that is the challenge which everybody is facing. What about the human intervention? If we are talking about artificial general intelligence or super intelligence, what will happen then? What will happen to our thought, intuition, and will we be required in between? So these are certain questions which are still gray areas of research, ethics. Whether, what if suppose somebody is, say, about say there is a counseling line, and you make it automated with the AI, and a counseling line, so suicide prevention line, and people can come up with this idea that we'll automate it, because a person can take a decision even in the middle of the night that I want to commit a suicide. So will an operator be sitting there, or human entity will be there? How will you manage it? So AI may come into play, but whether it is guiding the person rightly or not, is there somebody supervising it? So it's still work in progress. So I would say we should tread cautiously. We should have more regulation. CDSU still not has mature regulations. What Sahi is doing is just scratching it. I mean, they have just started it. Who will do what? To what extent? What kind of AI we will accept and integrate? So if somebody comes with an AI solution and says that my AI is able to do it, will you adapt it? No. You need evidence. That evidence, how it should be presented to the regulatory authority, is already decided. What algorithm you will give, how you have to present the algorithm. If there is a black box decisions where AI takes a decision and you don't know and it doesn't tell you, will you accept it in health sector? No, you will not. So these kind of guidelines are already mentioned in SAI. Please read the document, because that will open a larger, it will be open for a larger discussion. We can take it some other time.
Yes, sir. Thank you, sir.
So there is one more question. Swale has written in the comment box.
Yes.
He's asking that according to the Indian Cyber Threat Report, the healthcare sector accounted for 21.82% of all detected cyber threats, making the most targeted industry in India. In light of the growing cyber risks, what measures can healthcare organization and policymakers adopt to strengthen the cyber security?
So right earlier, what was happening in health sector was, like, for example, if I come up with for example, I am from Uttarakhand and my secretary takes a decision that he should have a HIMS software where he should get feedbacks, which program is doing good, which is not doing good. Now he'll get all the feeds and synthesize data at his dashboard. But whether that dashboard is guarded or not, whether there is a cyber security thing is there or not, that was again given to the states for them to decide which agency will take care of cyber security threats and all. It has already happened in Uttarakhand, where a lot of data was actually just it was held for ransom or something like that, and that is a real challenge. Yes, it is a challenge. And now, the good thing of centralizing everything or making it into cloud is, for example, now we are going for e-Shushruth for all PHC CHCs. And only one agency, that is CDAC, is responsible for all the cybersecurity. So I am not building my own software. Government has already told everyone, please don't come up with your solutions. We are building for you. Please integrate here because it will be easier for us to provide you security. Now, whether those people who are sitting there in CDAC are able to, safeguard that data or not, that is again, it is in the domain of IT, and I'm sure they're working upon it. So that is one of the important things. Even the government, every government realizes that military and health data are some of the most secure data, and they should be secured. There have been instances when we are using platforms earlier, when we were using platforms in IDSP, the whole IDSP data had vanished. Please go through some online reports and you will realize that this has already happened long time back. But we are now ready and not ready to part with our data. That's why whenever, people are trying apps in, downloading from Google or Apple, health related apps, they should be very cautious because we are coming with our own apps. If you at all you need to wait for some time, don't just rush. You can experiment, but please don't rush into divulging your privacy data. That's why where we are telling don't upload your patients data to Google or whatever just to know what is happening. There are things which are coming up, Indian made for India, secure, and we have to wait for it and we have to contribute to it. So that is a real challenge and a real threat. Just imagine now when we are centralizing, the whole data can go from the center. Earlier it was disaggregated, so there are very little chances of getting, losing the data. So and data is more precious than anything else right now. So all your apps, everything is working on data. So it is the most precious thing. Even your personal data records, they should be very safe. And government is ensuring that. Abha ID, that's why it has been created, that nobody should be able to, even if the Aadhaar is broken, Abha will not be broken into. So that kind of segregation has already inbuilt in the system. Thank you.
Rightly said, sir. Thank you, sir. I think we don't have any more questions.
Right.
Shravani, you may go ahead and summarize the session.
Thank you, sir. Thank you for your insights on the topic. And now, as we reach the end of the today's session, it is my absolute honor to propose the vote of thanks. First and foremost, heartfelt thank you to our esteemed guest speaker, Dr. Mayank Badola, sir, for sharing such profound insights and time with us today. Your presentation was truly engaging, and especially the points that you have discussed today. I would like to summarize starting from Digital India mission to ABDM that you spoke, and even the DPDP Act and Sahi at the end. सही से अगर हम पढ़ ले तो और हम implement कर ले तो from identity to UPIs and then ABDM healthcare application layers that you spoke about, and then we also came to know about the ABHA scale, the scale of the integrity of its 14-digit ID. From there to we also saw the research agendas that you spoke, that the researchers can also look into the questions that are still there, from population scale clinical validation trials for the age AI diagnostics to testing algorithms bias, which we right now we are on, and you also answer some of the questions. Along with that, we saw the future course and possibilities in digital public health sector. So we are very honored to have you today here. We express our sincere gratitude to our organizing committees and Sneha ma'am, our editorial director at SarvArogya, the RISE Foundation, for their tireless effort in making this webinar a success. A special appreciation goes to our technical support team who are behind the scene and ensuring an uninterrupted online experience for this session. Finally, thank you to all of you, all the attendees. Your thoughtful questions made this session for today a deeply rewarding one. Thank you all again, and we look forward to seeing you at our future events. Have a wonderful day. Thank you.
Sir, just one last question. Sir, Kaushal Pallai has one question. Sir, see, he's asking that technology you have discussed, will it increase the jobs or the jobs will be gone? Because AI is often associated with stealing jobs and it is shown in a very negative light.
So very simple answer to that. lot of jobs, or rather say, a lot of traits or skills will be taken up by AI, but there will be a lot of new skills which we will require. And the need of the hour is to upgrade yourself. Everybody, no matter which field we are in, whether it is agriculture, electricity, whatever, you have to upgrade yourself, learn what AI is capable of doing. You need to discern and also think in future. So my suggestion to everyone is, please go to any AI LLM and just type in, no, I'm in this field, I'm an ophthalmologist, what impact AI will have upon me, and what is the best strategy. Make a strategy for me, how to upgrade myself in the future. I think that will give you a lot of insights, because AI is already, working upon it, and I am sure this is a very pertinent question, and you will get an insight as to what you have to do next. So my take on it is, please upgrade, upskill yourself, because a lot of things, for example, in X-ray digitization with CT and all, these are already, pathology. A lot of things are going to change in near future. So they are all going to get digitized. Law is going to get digitized. A lot of lawyers are worried. So, but that doesn't end the job. I mean, we had computers, era of computers, when we had no computers and the computers came, still we are using them. We didn't lose our jobs. We just upgraded our skills. We were augmented by it. So let us not spend too much of time fretting about it, but let us think how productive we can use it. And as you can see in the horizon itself, all Indians are actually working on AI. Even people in the villages are learning AI and taking help of AI. So we are really intelligent people, but we need to devise, frameworks right now, and think how our manpower needs to, work along with AI. So that is the whole idea. And as I said, please type in any of the Grok or whichever AI you like, and just find out what is there in store for you. I am sure it is giving you plenty of insights. Thank you. And again, I request all the doctors, if there are any, or public health professionals, please, this is an emerging field. There's a lot of interest. Engineers are entering into our field and giving you cues why we can't contribute to this field. We should be open enough, and we should also contribute in the development of AI and its tools, and integrate and digitize our data. I'm sure, I mean, I can even now tell you at 50%, I have no idea whether they have a ABHA ID or not. Please go through the site, see what is happening, where we are heading, whether we should be part of it or not. That is your individual decision. Thank you.
Thank you. Thank you so much, sir, for your time. Thank you. Such an insightful session. Thank you.
Right.
Thank you.
Thank you all. We are at the end of our session today. Thank you once again.
Thank you.